All right, thank you. So, this is kind of my most recent wheelhouse with managerial stuff. I graduate with my MBA in December on the 10th, so that's kind of been what I've been looking at as far as information lately is managerial stuff, and so was exciting for me to put together. So how to balance productivity and ergonomics in the vascular lab. So I thought this was pretty funny. I found this on Facebook. My daughter says that I'm old because people don't use Facebook anymore, but I guess I'm keeping it going. Overworked sonographers includes transducer, cold gel, torn rotator cuff, stat lower venous reflux in the waiting room. That's par for the course for an overworked sonographer. So I didn't have to wear that Halloween suit, and most of you didn't either because that's what we wear every day. So again, productivity and ergonomics, how do we balance that? So I take a pretty easy approach to managing things. Common sense is usually what rules the world for me. So ergonomics increases productivity and quality. There is no balance. If you don't have ergonomics, then you don't have productivity and you don't have quality. So I'm going to talk a little bit more about why I feel that way. So allowing for proper ultrasound ergonomics is the cost of doing business. I mean, that's what it is. In the ultrasound department, if you don't allow for the proper ergonomics, which is the proper bed, the proper machine that has the ability to move in the ways that it needs to be moved, the chair that's going to allow the sonographer to sit appropriately near the patient, be comfortable with their back and whatnot, that it's just not going to be productivity. You're not going to be able to increase that. So the direct cost of an imager, that's super easy to accept for a CEO, for an upper manager. They understand that because they say, okay, it's going to cost me X amount of dollars to go buy this ultrasound machine. They don't understand the indirect cost of ergonomics, and it can be a challenge to present that to someone in upper management. So this is something that will be very interesting to physician owners and upper management of any vascular lab or any ultrasound department anywhere. Sonographers are in pain. 90% of sonographers are working in pain of some sort, whether that's on a daily basis or whether that's just something that happens occasionally. And 20% of them actually end up losing their job over the fact that they have so much pain and while they're working. So it costs for an individual organization $771,500 for inappropriate ergonomic workflow for the sonographer. That's what it's just going to cost you just in the bills for low productivity because the sonographer can't do as much as they're supposed to because they're working in pain. That's how much it's going to cost because they're going to have to be out because they're having back surgery, shoulder surgery, wrist surgery, etc. So that's just something to keep in mind as far as the sonographer themselves and how much work you are placing on them. So how do we check the productivity box while working ergonomically? I mean, that is the question. So how do we make sure that we are meeting the appropriate productivity? Because it's not just about dollars and cents. Although we want to make money, and we are. I currently work for a for-profit company, and many of you do as well. So you do want to make money. You don't want to lose money. So it's important to make sure you have that balance of how much money do you need to make in order to keep the lab afloat. In most places, the lab keeps the other departments afloat because it makes so much money. So it's important to figure out what that balance is and how much money do you need to take from the vascular lab to keep the clinic running because the clinic is losing money or whatever the process may be for that particular process. So that's where capacity management comes in. So capacity management is the act of ensuring a business always maximizes its potential activities and production output under all conditions. So that's just the basic managerial definition for capacity management. So I'm going to give you examples of where I work, and it's not going to fit specifically with where everyone else works. I'm going to give you real life numbers from the organization that I work for, and the difference is You may have more or less sonographers. You may have more or less patients. You may have more or less physicians. So you're going to have to figure out in your organization what that happy balance is between one and the other. So in our organization, we have decided that one sonographer can do 7.5 exams in a day. We work from 8 to 4:30. We see patients from 8 o'clock in the morning until 4:30 in the afternoon with a lunch break in the middle. So first off, we start our first patient at 8:15. So the sonographer has time to come in, clock in, get themselves appropriately ready, and chart prep if they need to, or prepare for the first patient and get ready for the day. Then their 8:15 patient starts at 8:15. We continue that until 12:15. They get a 30-minute lunch from 12:15 to 12:45, and they have another 15 minutes of non-productive time where they have the ability to prepare for the afternoon, whether that's get more equipment, get more supplies, prepare their room to start the last half of the day, and then they work until 4:30, and then they clean up and leave. So that's just sort of the process that we have for our group. 7.5 for sonographer, which means 15 for 2 sonographers, 22.5 for 3 sonographers, and 30 for 4 sonographers. So currently, I have 8 sonographers, and I'm always sending someone out to a satellite office. So if you're looking at just my main office, we have 6 sonographers who are working all day long every day. So we can do 60 exams. That's it. That's what we do. I had a physician that I worked with. His name was George Pliegas. We used to always, he was an awesome physician, but he would come to us and he would say, hey, can you do a quick ultrasound? Can you just do me a real quick ultrasound? No problem, just real quick. I just need you to look at just this. This is no problem. Well, what he didn't understand was we have a protocol we have to follow. There's certain pictures that we have to take in order to be able to charge something. Now, if you want me to not charge for a patient and I don't have an exam, or I've got plenty of time in between my exam and the next exam, sure, I can look at anything you want me to look at. But if you want me to do a full bilateral LEA with ABIs and exercise on this patient, which was usually what he was asking for when he wanted that quick ultrasound, no, I can't do that in the 15 minutes I have before my next patient starts. So that's kind of where it becomes important for there to be a little bit of management of the physicians and how they have emergent work-ins, how we handle those emergent work-ins. They truly are emergent patients that need to be taken care of. So there's got to be a way to handle that. Who's going to take on the excess? If you're already full to capacity for the day, what's the answer for that? So this is just a list. So I told you I was going to give you some real life numbers. So this is our productivity for the year of 2022. And so each category going across from left to right is an individual. We schedule all of our exams by room, and each sonographer has their own room, and we don't share rooms. So room 1 is worked by an individual, and that one room is who that person is. So these numbers are so different from sonographer to sonographer because one person may have worked for 25 years and have 5 years of vacation. So obviously in that time frame, if they're going to take a week off of vacation, they're not going to have worked as much as the person next to them who didn't take off a week of vacation. That's important to remember when you're comparing sonographer to sonographer, that yes, this person did 100 more exams, but they also didn't take a vacation, so you can't fault the one who did take the vacation. That's why we work, is so we can live, right? And take care of patients. So if you're looking here across from left to right, we've got the first sonographer's done 1366 exams. I know who this person is. They're in order from room 1 to room 7. And so that's the most recent sonographer that we've hired. This person doesn't have any PTO yet and hasn't chosen to use any. So that's why they have such a high number of exams that they've completed. And then so forth and so on. You can see how it kind of matches as you go down for the other sonographers who have worked from year to year and does have extra time to take. The black lines, that's just because we had someone leave and someone could come back and fill their spot. So that's where someone left and we have a new hire in that position. So I blacked out where the old person did have exams. So you can see on the third line, there's only 150 in September. That's where the new person started. But there was exams that were happening in that room all year long, and we do want to be able to forecast in the future. And we'll talk a little bit more about that as we go. So, like I said, we want to average 7.5 exams. Now, what does 7.5 exams mean? It's not patients, because when we have patients who have vasculopathic disease, I don't know if I just made that word up or not, but We've got vascular path patients who come in and they've got a carotid, they've got an aorta, they've got a renal, and then they've also got bilateral LEAs that need, SFA stents. That doesn't count as one patient. Each one of those exams counts separately. Now, we do decrease the amount of time that individual sonographer gets for that particular exam. We give 90 minutes for a lower extremity arterial and bilateral ABI. And so if they're doing a carotid, separately we give 45 minutes. If we combine the two, we take 15 minutes off of the second exam and combine the two together to make the one exam time for that patient. And so that's how we keep everything going, keep everybody happy, keep everyone from being hurt, and just manage their expectations as well. So you can see that in our first quarter, we didn't quite meet our 7.5 CPT or 7.5 exam code per tech. We were at 7.43. Then we increased to 7.56. And then again, the end of this third quarter, we dropped back down to 6.99. And over on the far left of that bottom box where all the green and red is, you can see the 2021 numbers where we were an overall year average of 7.7 for the whole year. So we're probably going to fall a little bit short, but we also had one more sonographer in 2022 than we did in 2021. So we would expect those numbers to decrease a little bit because we're having to spread that workflow out. So all of this goes in together to determine how you're going to come up with your numbers for your lab. I also keep up with exactly how many days each sonographer works. There's usually 22 days in a month that are working days, if there's a 30-day month. So you can see the number of days, and some of them had overtime, some of them had undertime, and so there is a point where we keep up with 22.7 days for January for the first person on the list. And you can also see where that person worked 183 days between January and October because they didn't take any days off. And then everyone else is somewhere in between based off of how much time they took off. All of that equals up to this. There used to be a time in my life when I looked at this kind of stuff and I didn't care. And there used to be a time when I looked at it and I was like, okay, that looks like a waveform. That looks like a really bad venous waveform. Now I see seasonality, irregularity, and trend. And what that means is we are working in a organization that has seasonality. There's irregularity to our productivity, as well as a trend. And if you see the orange line, this starts in 2016, which is when I started at the organization that I'm at now, and it goes all the way to the far right-hand side where it's trending upward. And then you can also see COVID. So you can't forecast for COVID. There's no way to forecast for COVID. So you can forecast for productivity the same way that you forecast for marketing, forecast for your financials moving forward in every business. So we do forecast, and the way that we do our forecast is there's a specific algorithm that you can use and you can put together in a Excel spreadsheet, and it's way more than what we need to go over today, but it gives you within certain percent of error the forecasted productivity for the following year. And so I don't know how many of you guys, managers or upper management, do that kind of thing, but that's what tells you how many sonographers you need for the year. If you can only do 60 exams a day, you can't order 75, because if you order 75 and you only have the capacity to do 60, somebody's either working overtime or you're overworking all of your sonographers together. So that's the important key distinction. So now I go back up and I go to, okay, well, what do you do with the emergent sonographers, or the emergent patients that come in that really need to be taken care of on the day-to-day basis? When I was in the role of technical director, I didn't run a room whatsoever at all. My job was to make sure that the day-to-day operations of the organization was being taken care of, and if there was an emergent patient, I did that myself. And I think that that's a decent model. It doesn't work for all organizations because some managerial jobs or some folks that are in technical director positions don't scan at all and don't have the capacity to do that. And that's fine, but you got to find out, okay, well then does that mean we need to hire a PRN person that's going to come in and they're going to work the awesome schedule of 10 to 3 every day? and they're going to be able to drop their kids off from school. They're going to be able to pick their kids up from school. You're making them happy, and they get to have that nice schedule of they get to sleep in late if they don't have kids, and they get to leave work early. You can find people out there that are willing to do that if you can find anybody at all. So that's kind of my spiel about forecasting and productivity. So the psychology of productivity, how do I manage productivity? How do I increase, it's really hard to read, how do I increase the ergonomic standards? How do I increase quality standards? And how do I increase the favorable patient outcomes? How do I increase the department's profitability? Basically, the answer to all of that is it's common sense. You've got to have the right number of people to do the right number of exams. So if we go back just a little bit and look at a little bit of the productivity model, our busiest month every year is March. You can look at each peak that's the highest is March, and each peak that's the lowest is December. So you would encourage your folks not to take vacation in March if that's possible. You can't always predict that, but if you know you're going to have those your highest productivity months, then that's when you would encourage your folks and you would get them together in meetings and say, hey, look, we don't want to kill everybody here, so let's try not to have as much vacation as we can in March as possible, and then give as much vacation away in December as you want. Number one, at least in the organization that I'm at, half the doctors are done on December the 15th anyway. They're only doing what they absolutely have to between that point and January the 1st. So give them the vacations that they need. My theory on why March is always the month is because obviously deductibles start back over again in January. So people who would have come in December with the same regular amount of pain are saying, you know what, I'm going to see if I can hold off on that just a little bit longer because my foot's hurting, but I don't want to go in and see Dr. Lassar because he's going to charge me a copay or it's going to cost me a surgery, whatever that may be, depending on their insurance and their situation. So they're more willing to wait through January and through February, and then they're like, oh crap, I've gone 2 months now, my foot's going to have to come off. I got to go see Dr. Lassar and get this fixed before it's too late. So that's why everybody comes in the month of March. So I will entertain questions at the end if there's still time, but thank you very much, and I appreciate your time, and thanks for inviting me.
Thank you, Josh. It's nice to know we all have the same struggles, but that was very good, and I, for one, got a lot out of it. So we're going to move on a little bit in the same theme and talk just a little bit about accreditation. So basically, yes or no, are you on the bandwagon to have your lab accredited, or do you think not? So the IEC is our accrediting body that was founded by medical professionals to advance appropriate utilization, standardization, and quality of diagnostic imaging correlating with intervention-based procedures. When I was doing a little research on this talk, I found it interesting and gratifying that the IAC was founded originally and named ICAVL because it was founded to accredit vascular laboratories. So that made me feel good because the vascular ultrasound and field in general has always sought to strive to have better, good, standardized testing standards and tried to be the best it could be. So the IAC is the only accrediting body that is nationally recognized and CMS approved. So Josh talked a little bit about productivity and why it's important. The labs have to make money. We all care about good patient outcomes, and we want to take care of patients, but we have to think about the economics as well. I don't know about you. I love what I do. I'm very passionate about it. But if Dr. Lassard didn't pay me, I probably would go somewhere else because I have bills to pay. But so we're always striving to maintain that balance between good patient care and economics, all those good things. So the IAC over the past few years has kind of trended toward clinical peer review of case studies. And I think this is really important. It not only looks at the diagnostic quality of our imaging, but the accuracy of our reporting, the completeness of the report, and that it's an educational process. It's not punitive. It's not, oh, you missed this stenosis and you need to do better, but it's, oh, how can we keep from missing this again? What can we do to improve ourselves so that we don't miss it the next time? If you choose to have your lab accredited, you can use it as a gold standard. There's competition in every field: vascular surgery, vascular labs, no different from anything else. There's competition out there. So you can make yourself stand out to your patients. Our lab meets rigorous standards. We're IAC accredited, and patients are looking at that now. They're looking, they want to go to places that they know that there's some quality there. There's a standard that imaging, that vascular lab meets. You can also show referring physicians. Our patients have better patient outcomes because we focus on quality, and we set a standard for that. So your patients are getting good, better outcomes because of what we do in our lab, helping the surgeons. And then also, it shows new hires that you emphasize quality. Josh talked about not overworking staff and how that leads to better productivity. So nobody wants to go to work in a place where they think they're going to be overworked. So you value quality as well as productivity in where you work. So show me the money. Why should my lab invest in what it takes to be accredited? So if you're IAC accredited, you meet, you're compliant with reimbursement mandates, and more states and private payers are requiring accreditation, whether that's for the staff or the facility. So it's not tied to reimbursement, but it's going in that direction. More and more states and private payers are requiring that there be some type of accreditation in the lab. Like I alluded to just a few minutes in earlier slides, our lab is an accredited lab in what we do. So decision, what are the pros, what are the cons for accreditation? So there's ongoing quality improvement measures, and like I said, it leads to better patient outcomes. The emphasis on peer review, not just the emphasis being on, well, what are your correlation statistics, but the peer review of the cases. So I have found, managing the lab, that when employees are engaged in reviewing cases, not just their own, but their peers, it makes them more engaged in what they're doing. They are looking at their peers and what they're doing, and they're thinking, oh, I didn't realize that that's what they were doing. So they become more, oh, I can do that as well. They're more engaged in what they're doing. And when you're engaged and you have a passion for what you're doing, then you tend to be more productive. So I'm big on employee engagement. Improved adherence to protocols. So when you are paying attention to what your protocols are and you're looking to make sure there's continuity in your lab, that all your techs are doing the same thing in the same way, it just makes things smoother and easier as well on the physicians. They know that they can depend on the tech in room 1 says it's a 50 to 69% lesion in the carotid, in the internal carotid, that the tech in room 4, they're saying the same thing. There's conformity and continuity in the lab, and it doesn't matter who's doing the study. And then also, there's a marketing tool there in a very competitive field. All of our techs are registered. We have standards that we meet. So you can depend on what we put out there for your patients. Some of the cons, there's a cost associated with it. And just like with everything, do we want to spend the money to get our lab accredited? You have to dedicate staff instead of just doing what they do, scan patients. They have to spend time working on the application process, and some of that paperwork that's always required whenever you enter into any kind of process, so you have to dedicate that time to it. And then maybe the standards that the IAC has put out there. I think somebody said earlier, it might have been Josh, the IAC put out a few years ago talking about the standing on the reflex studies versus reverse Trendelenburg. Maybe the docs you work for have one view or another, and they don't want to abide by the standards that the IAC puts out because your surgeons want something different, and that's okay. So you have to weigh the pros and the cons about whether or not you think it's important. So I liked this when I was trying to put this talk together. We are what we repeatedly do. Excellence, then, it's not an act but a habit. You're here today because you want to have a better understanding of vascular disease. You care about what you do. So that's what your thought process, that's what you're focused on. And if you make it a habit, then it's an excellent habit. So that is all I have on accreditation. So I'm going to have him load up the next talk because that's mine too. And if you have any questions for myself or Josh at the end, you can ask. So when Dr. Lassar and I were talking about whether or not we wanted to do this conference, I wanted to talk about the unique role of the vascular sonographer because that's my passion. When I got involved in vascular ultrasound, I found it's become my passion. I have some patients say, "You enjoy what you do, don't you?" It comes out in how I deal with my patients because I believe I'm helping patients when I find the disease, and I'm helping make a difference in their life. And I have always valued my role and the relationship that I've always had with vascular surgery. So basically, the scope of practice for the diagnostic medical electrical sonographer. I got this from the ARDMS website. Independent, professional, ethical judgment, and critical thinking to safely perform diagnostic sonographic procedures. So that was taken from the ARDMS website. So what sets us apart from that general sonographer? And I think we're the next level. Some of you may have a general ultrasound background, don't be offended. But I think the vascular sonographer is the next level because we engage in critical thinking every day in what we do. We are a skilled and knowledgeable vascular sonographer plays a fundamental role in advanced treatments for vascular disease. Catherine talked about in her talk earlier today, there is a 1-to-1 correlation with venous disease and getting the patient the correct treatment. You show up ready to play. You show up in that ultrasound room wanting to do the best you can for your patient. When you show up with that attitude, you're going to do the best you can for that patient. And sometimes that involves that critical thinking. That is what a vascular technologist does. We are the eyes and the ears of the provider. We find the disease. Early in my career, I worked with a tech, and she was training. And sometimes she would come out of the room and go, "There's something going on, and I can't find it." So she would get one of the senior sonographers to come in because she knew there was something going on, she just couldn't find it. She wanted to find the disease. So you apply your critical thinking skills. Like Josh said, you work smarter, not harder. There are certain things we have to do in an ultrasound exam because we're charging insurance for it, right? There are coding requirements. There are certain images we have to take. Like Josh said, I just need you to do this one, just do this quick ultrasound. Well, if I'm going to charge for it, there are certain images I have to take. So you can't just do a quick ultrasound sometimes because you never know when you start what you're going to get into. And if you're a good vascular sonographer, you're not going to stop until you find it. Even if that means going out of the room. I've been scanning for a long time, and I still sometimes go, "Hey, can somebody come in here and help me find, there's something going on and I can't find it." So there are requirements, they're not just coding requirements, but there are IEC requirements because we're an accredited lab. So there are certain images that, because we hold ourselves to these certain standards, we have to document. That doesn't mean you take a picture of everything. So you no more, no less. So you take what you need to take, you satisfy the coding, you satisfy the IC, and then if that's all you need to do, you're done. But if there's something else going on, that's where that critical thinking comes in. You keep going, you chase it. Dr. Lassar had a patient last week, and he said, "I need somebody in the OBL," came over there, and I was like, "Okay, give me the lowdown on what's going on with this patient." I'm trying to fit it into the middle of a busy day. So I gave him a little bit, and I said, "This is what's going on." He says, "Okay, well, if such and such, chase it." Like he's telling me if that is normal, then keep chasing what's wrong. Find me, find the problem. So I have tried to work towards our protocols, making it to where we apply those critical thinking to our protocols. Our lower extremity arterial algorithm is a combination of Rutherford category and ABI. We don't just take A, B, C, D pictures. We take A, and if A is this, then you go to B. If A is this, you can skip B and go to C. So that's the critical thinking part that empowers your techs to deviate from the protocol. Don't just check the box of the pictures you're taking. Take the picture and then decide, is this going on? Do I need to go further? And that's what sets vascular ultrasound, and that's why I'm passionate about it, because it empowers me to find out what's wrong with my patient. Advocate for your patient, even if you can't find the disease. I've told many students and many new techs, I would rather you come out of the room and say, there's something going on, I can't find it. It doesn't mean you don't know what you're doing. It just means you're passionate about doing what's right for your patient. So to me, that's more important than just us checking boxes off. Like, you want to find, it doesn't make sense, so have somebody else help you. So there's also the other piece of that. I can take excellent, pretty pictures all day long, but if I can't interpret those pictures and draw my provider a picture of what's going on, then I've not done my best. So you not only have to take the right pictures, but you have to understand those pictures and be able to interpret that to give those results to your provider, and effectively communicate what's going on with that patient. I know when I was a younger tech, it would take me, and I think Dr. Lassar will attest to this, I've been told many times by vascular surgeons, get to the point, Tina. Like, it took me a minute to figure out what was important and what was just extraneous, right? So I've been cut off many times early in my career because I like to talk and tell them everything because I was excited about it. But I learned over the years to get to the point. He needs to know that other stuff, but maybe not through a circulator in an OR when he's, elbow deep in a AAA. I was very excited, them not so much sometimes, but communicating what's going on with that patient, getting straight to the point, that's that unique relationship when you're working with a vascular surgeon and you learn to speak their language. You know how to report your findings, you know the clinical significance. That's what sets the vascular ultrasound sonographer apart from just a picture taker. So the high-performing VIC technologist, so I'm going to brag a little bit because it's our conference and I can, but the high-performing VIC sonographer is efficient and friendly when rooming the patient, acquires images needed for accurate diagnosis, no more, no less. Don't just take pictures because you're taking pictures. If you can take 2 pictures and it describe what's going on, then don't take 5. You're working harder, not smarter. Makes and reports accurate conclusion about the exam and communicates effectively. So these things are all important. Who benefits? Well, of course, the patients benefit. Ultrasound, like Dr. Lassar has said a few times earlier, these other imaging modalities are great, but they're a lot of money, right? They cost the patient a lot of money, and they get radiated. Ultrasound is low-cost, non-invasive, and there's very few contraindications to ultrasound. In the hands of a knowledgeable and skilled vascular sonographer can get the surgeon or the provider everything they need to help treat that patient. If we still can't, then they go to these other imaging modalities. For the providers, it gives them dynamic, real-time images, and immediate results. We have patients that come into our practice, get seen, they get referred within, they get seen within 3 days. They get an ultrasound maybe that day or the next. They can be from being referred to intervention within 3 days sometimes. And that's, we're not waiting a long time for results. We can communicate with our surgeons, this is what's going on with the patient, so they can make good decisions. So we're just one member of the healthcare team, and we're very proud of what we do here at VIC. And I hope that everyone enjoyed today's lectures. I know I certainly did. And I'm going to invite Dr. Lassar up here. In case he forgets, we're going to do the drawing for the gift card. If you visited the vendors, and put your name in the hat.
Well, of course, Tina, I did not forget that. I mean, I just wanted to comment, just a couple of comments. First of all, I think it's been an excellent session. I think there's a unique role for the vascular sonographer in a vascular surgeon's practice for a couple of reasons. One is it's the programs that we can actually accomplish, because there's so much to do in my particular world, and so many different things where we're called into focus on different things. But how do you move the ball? That's the big question. And for our critical limb program to do the PATs and do it right, I couldn't do that without this team. This team has really organized themselves to do that. How do we understand deep venous and really build that program? Well, we have to have the right kind of imaging and the right kind of thought process, and it's building the program. And the newest program is under our belts, the wavelength program for the endovascular fistula. I think there's a lot of advantages for our patients, and it's that team that really comes together that really creates that. So I've always said that our vascular unit is the heart of our practice. I mean it. It's absolutely true, and I applaud everybody for their passion today, and I really appreciate the level of engagement that the audience has had and the techs in this room have had for making this a great conference. Couple of logistical things that we just need to talk about. This is an 8-hour CME course associated with the Tennessee Medical Association, and it's approved for that. The way things work is that everybody here will get an email, and you'll need to send in your comments and evaluate the course. I really encourage you to be verbose about it. I want to know what works, what doesn't work, what we need to do next year, what we're missing, because this is our first time. And then at that point, you'll be emailed the CME credits through the TMA process. And that's really all I'd like to have to say, but I just want to thank everybody for what a great course today, and for all those people who traveled and the efforts everybody put in. So the next most important thing is the drawing. So Chad, why don't you, Tina? Actually, Chad, will you draw it for us from Tina? I'll get to read it. All right, and the winner is Stacy Hill. Congratulations. Now, we are just a little early. I don't know where you claim your prize at, but we'll have to figure that out. We are just, we've actually been on time. Everybody's done a really good job of the timing of your talks. We've had 2 sessions that have gone through, and starting with the endo-AV fistula, the mesenteric disease, a couple interesting cases on the popliteal arteries, aneurysm. I thought that was cool. and then the ergonomics and accreditation. So is there any questions about any of those topics at all? I'd be curious just to entertain those, and then we'll wrap up here in a few minutes. Yes, ma'am.
Thank you. When they do the waveline fistula,
Yes.
how long does it take for healing time before it's usable?
So that's a great question. It really depends on how well the fistula takes. We've we've attempted 30 times. We've completed 28 fistulas. If they have a really good fistula immediately after, the great perforator leads right into the cephalic vein, let's say, it can be as early as 4 weeks, but that's really on the exceptional side. Generally, it's about 6 to 12 weeks, more often 12, and we do get that split fistula sometimes. The basilic develops, the median cubital vein develops, so I don't need to do surgery and transpose the basilic vein any further. That median cubital is enough of a landing zone where they can access. And so I think we get a lot of other access points for that. I'd say we have about 75% of people actively, that might be a little bit much, maybe about 60% are actively using the fistula. About half of the patients were CK4, 5. They were not on dialysis yet. They were in that pre-stage. And we're just evaluating, this process. But at this point, the vast majority, 85% of patients have a usable fistula when they need it. So, good question. Yes, sir.
What helps you decide when to embolize the radial vein?
Yeah. Why do that? Yeah. Yeah. Like, why do that?
Well, no, I know why you do it, but I'm saying, do you have a concern that you're going to cause some harm swelling?
Sure. Yeah. So the answer is absolutely concerned. That's one of the things. When you do the imaging and you create the fistula and you can look at the venous outflow when you inject into that arterial system, you can see that the venous outflow. And if it's robust, you have the option of coiling one of the larger branches. You would not want to coil both branches because then what you described is that you can get this almost like a compartment type syndrome where blood's getting pumped in, blood can't get out very well, and you can get swelling in that forearm and pain. We had one patient that was similar. We thought we may have done a problem like that, but she still had a very good venous outflow. So you have to be judicious in your embolization when you're doing that, but it does promote that flow from the deep system to the superficial system. And just trying to find that balance, just like we do in surgery, to balance how big the anastomoses are when we're actually creating the surgical fistulas. You can make an anastomosis too big and steal all the blood, or you can make it too small and it not develop. So there's just a balance of how you do it. It's a good question.
Yeah, I have a
Tiff.
question because I teach a lot about the mapping and the post-operative, but I have not worked with someone who's done nearly as many as you're doing now. Central vein stenosis, where if there are multiple vein outflow tracts and you may have to come down to having just one main one if the other ones aren't performing. A lot of times for post-AVF or AVG, follow it all the way into the central system.
Yeah.
Have you had enough longevity with this to know whether central vein stenosis
Yep.
is as prevalent or less
So
prevalent?
I don't know yet, but here's the thought behind it. When you have a surgical fistula, you have all the flow going through one pipe, and that pipe will then tend to get very large sometimes, and you get high volume flows, 1.5 liters, 2 liters of flow. And that turbulence, as they branch, as they hit the central veins, that's where they tend to create the narrowing. The wavelength fistulas are a low flow fistula. That's how I call it. And so it's about 600 cc's, max 800 cc's a minute. We've had a couple that are just really robust, that are large or more 1,000 cc's per minute. But predominantly, it's just a lower flow fistula. So it's not, the dialysis access or the dialysis units have a hard time accessing the fistula sometimes because they're used to popping the needle in because it's robust. These veins are acting more like your normal veins. They're soft, they're pliable. So you may not get that turbulence that you have. So I'm hopeful that we don't get the central venous syndrome that we have with surgical fistula. Don't know that answer yet, but that's kind of my thoughts on it. Will?
This may be along the same lines, like, why is it less likely to develop aneurysm than the traditional outflow tract of the cephalic vein or bacillic? I mean, is it because it's distributing some of that venous
Yeah,
fistula flow?
yeah, I think you're right, because so the thoughts behind the wavelength fistulas is that you have less thrombosis in this situation because you have multiple outflow channels, and when you have the surgical fistula, our mindset is to create as much flow into that one channel so that really develops, and it works. But the complication, the downside effect of that is that vein can become aneurysmal. It can cause central venous syndrome, where they stenose things. But that's the downside of a really good fistula. And what you want is a balance. I would say you don't want as much flow if you can avoid it, and cause the turbulence that will happen. But fistulas tend to get better over time. So, you know, it may be we still get those syndromes. We just don't know yet. It's just too early to say. All right. Is there any other questions that they wanted to ask any of the other panelists? I think we've achieved our goals today. Everybody stayed awake. I didn't see anybody fall asleep. This is good. And I think we had a great session, and a lot of knowledge that we shared. And I appreciate everybody who's traveled so far to be here. It makes a world of difference to us. So I want to officially close the first annual the FACES Ultrasound Conference, and I want to thank everybody for the participation, and for all those in the ether. I hope that this was a great conference for you. You can let your friends know they can view this online and still get CME for up to a year after this. I believe that's true. This will be on our websites, hopefully in the next couple weeks, where people can review this and still gain the CME for this. All right, thanks everybody for attending.